Hello, it's good to be here with you today. I'm going to be talking to you in some detail today about a phenomenon known as post-intensive care syndrome, or PICS. My name is Jim Jackson, and I am a psychologist and assistant professor of medicine at Vanderbilt University Medical Center. I've been studying PICS and related issues. I'm not advancing here for some reason. I'm
Okay, I'm going to stop it again and start again.
Jim Jackson. I'm a psychologist and assistant professor at Vanderbilt University School of Medicine and the assistant director at the Vanderbilt ICU Recovery Center. I don't have any conflicts of interest to disclose. I'm here today to talk about post-intensive care syndrome, issues and answers. Post-intensive care syndrome, as you'll soon find out, is a characteristic condition that affects survivors of critical illness. It affects them across a range of domains, and we are going to unpack a wide range of issues related to PICS. In the process, we'll provide some answers and highlight what relevant questions related to PICS continue to be. We have a number of course objectives here today. One of them certainly is to define post-intensive care syndrome and its many manifestations. Another objective is to examine how PICS affects patients and families, and still another objective pertains to identifying common ICU practices that lead to the development of PICS. We will certainly talk a bit as well about the way that people are currently engaged in treating patients and family members with PICS, and hopefully that discussion will be useful. We have a lot of ground to cover today, so we will move rapidly. Thank you for your attention. We have a number of references that we are going to discuss today, perhaps not explicitly, but many of the comments contained across the slides will be derived from what we call these key references, these foundational references for continuity of care. There are certainly many more than this, but the 2 pages of references that you see are, generally speaking, the seminal references in the field pertaining both to physical outcomes, cognitive outcomes, and mental health outcomes in survivors of critical illness. You'll see an image here in front of you of a man sitting in a chair. He's got his head in his hands, and there's a shattered window in front of him. I included this image because I think this is a powerful portrayal of the broken lives that people feel like they experience after surviving the ICU, in this case surviving sepsis. The problems that people experience are significant and real. Often in the context of these problems, they're left feeling very discouraged and despondent. This is a visual representation, an artistic rendering of what is often going on internally in the lives of ICU survivors, and I would ask you to reflect on that because in many ways it frames the topics that we're going to discuss today. Post-intensive care syndrome is a new term. The term PICS was agreed on as the recommended term to use at a 2010 SCCM task force meeting. This is highlighted in a paper. You'll see the reference there by Dale Needham in Critical Care Medicine in 2012. PICS refers to new or worsening impairments in physical, cognitive, or mental health status arising after critical illness and persisting beyond acute care hospitalization. We've struggled a bit, I think, in the field to figure out what exactly to call this condition. It isn't simply cognitive impairment, it isn't simply mental health debility, nor is it simply physical disability. All too often, it's a combination of these things and does in key respects fit the definition of a syndrome. So this term PICS, although new, is increasingly used to describe the gestalt, the totality of problems that people face, and of course you'll hear me referring a lot to it today. Cognitive problems are particularly devastating for ICU survivors, and we're going to unpack them in some detail. Cognitive impairment is common in between 40 and 60% of ICU survivors, and it happens in a range of different domains. It happens in executive functioning, it happens in memory, it happens in attention. Memory and attention are constructs that people are generally quite familiar with, and indeed you are probably yourself familiar with. Executive functioning is a term that may be a bit unfamiliar, but briefly, executive functioning refers to planning, multitasking, organizing, shifting attention. Executive functions are really believed to be functions crucial for independent living, for higher order functioning, and when they are impaired, the ability to manage effectively in the workplace, the ability to drive, the ability to manage a complex medication schedule, those things are all at risk. So I will discuss in some detail all of these three things, but want to make sure we're clear about definitions. I would mention, too, as we talk about cognitive impairment, and we'll do that going forward, sometimes deficits in memory look like deficits in attention. Sometimes attentional deficits present as memory problems. We'll talk about that in some detail, but let's begin by framing issues related to cognitive impairment. There was a paper that Pratik Panharapandi and many of us at the Vanderbilt ICU Delirium Group published in the New England Journal of Medicine in 2013, simply called Long-Term Cognitive Impairment After Critical Illness. And I include this here to highlight what we know about cognitive outcomes in survivors of intensive care. This was certainly not the first paper to engage this issue of cognitive impairment after critical illness, but among prospective studies, it is the largest, and we'll wade in and talk about what that paper showed, and then frame the results against the backdrop of what we know from other research as well. You'll see here in a slide entitled "The Picture of Cognitive Impairment Following ICU Care" that there are a number of horizontal lines represented on the screen in front of you here, a green line, a brown line, a pink line, for instance. They represent normal functioning, mild cognitive impairment, traumatic brain injury, Alzheimer's disease. Let me unpack for you quickly what is represented here. You'll see boxes with a solid line. Those boxes represent the mean scores of ICU survivors in our brain ICU study. And you'll note that in patients below 65, older than 65, they typically earn scores on a test called the R-bands in the low 80s. The R-bands is a widely used measure of cognitive functioning with a mean of 100 and a standard deviation of 15. So what you'll note there is that in the main, most of our patients in this large brain ICU study of 800 and some patients scored well below normal on the R-bands on this popular and sensitive neuropsychological measure. Importantly, what the slide in front of you shows is that people did very poorly on this test, whether they were older or whether they were younger. This was true with regard to global cognitive impairment. This was true across individual domains. What's the point? The point is that we're finding that cognitive impairment after intensive care is not simply a condition of old age. That is, old patients, young patients, they are really all vulnerable to the effects of critical illness. Cognitive impairment after critical illness is not just a phenomenon among the old or very old. It is something that all too commonly happens in people who are young, people who are middle-aged, people who are, in many cases, at the height of their functioning, people for whom incident cognitive impairment is quite devastating. I'm showing you here actual pictures of a patient who completed a test called the Ray-O copy test, the Ray-Ostrith complex figure copy test. You'll note in the upper quadrant of the slide there's a complex geometric figure. In our neuropsychological testing, we show that figure, show that picture to patients. We ask them to copy it. Immediately thereafter, we ask them to draw it from memory. interestingly, when we have done this with our patients, they have done quite poorly from the standpoint of copying, but where we have seen really striking problems with cognitively impaired ICU patients is in memory, visual memory. In the example in front of you, you see a copy that is a reasonably representative rendering, and then you see a delayed memory version that actually is clearly not the figure they were shown. In fact, it's a house or a barn. This is an interesting example of confabulation, a process by which patients don't remember all of what they were shown, but remember some things that they weren't shown. For instance, this patient likely remembered that this complex figure looked a little bit like a rectangle. He or she likely remembered that this complex figure had what looked like a roof line. They thought to themselves, what involves a rectangle? What involves a roof line? Must be a barn, and that's what happened here. So we see some really striking distortions occur in our patients, and it's quite interesting. This is another example. This is from a paper we published in 2003. These are pictures of copies that patients had done of the figure that we just showed you, a normal figure, which looks like quite a nice rendering, a figure that really looks a lot like a series of scratches on the page on the far right, which were observed in a severely impaired 72-year-old ARDS survivors. So they say a picture's worth 1,000 words, and we certainly find that's true in our research. You can see that our patients have really striking visual spatial problems. They have really striking problems with memory. I would highlight that these visual spatial problems are quite concerning indeed, because what we know is that activities like driving, to name one, are powerfully influenced by visual spatial ability. So to the extent that we see ICU survivors, people with PICS, cognitive impairment, who have new onset visual spatial problems, we worry about their ability to manage daily activities, driving being one of them. You'll see here an abnormal clock drawing. This is from a patient in our Vanderbilt ICU Recovery Center. And the clock drawing is an interesting test that people use because although it is very short and easily administered, it is a very nice measure of planning and organizing. You'll see here that someone essentially forgot to place the hands on the clock. You'll see here that the relationship between the numbers was hugely distorted. Again, executive problems are common in our patients, and it's quite concerning. This is an abnormal clock drawing. There are a number of clinical practice guidelines that have been engaged for the management of pain and agitation and delirium, and these are important. There are fewer guidelines to help us as they relate to the management of cognitive impairment, and we think that's a problem. Certainly we need to be more adept at not only understanding how to thoughtfully engage pain and agitation and delirium, but also how we can thoughtfully engage mental health issues, physical issues, cognitive issues. I think I've highlighted that cognitive issues are common in ICU survivors. Let's wade into a discussion about mental health problems. Mental health problems in ICU survivors are variable, but they include a clinically significant anxiety, they include really striking symptoms of depression, they include post-traumatic stress disorder symptoms that exist but sometimes fail to rise to the level of a formal diagnosis of PTSD, and in other cases they involve clinically diagnosable, functionally debilitating post-traumatic stress disorder. These are the four horsemen of the apocalypse, if you will, for our ICU survivors from a mental health standpoint: anxiety, depression, subclinical PTSD, and then the full-blown entity PTSD. So let's wade in and look at what we know. If we look at psychological morbidity of patients, that is of ICU survivors, people who have PICS, it is quite concerning. If you look at point prevalence with regard to depressive symptoms, you'll note that in some studies up to 40% of patients have clinically significant symptoms of depression. With respect to PTSD, The numbers are continuing to be debated even now. Some very recent studies have suggested that PTSD is perhaps somewhat less common than has been reported in previous studies. But again, if you look at a number of well-respected, well-regarded studies of PTSD on this slide in the set here, you'll see rates of that condition, or at least symptoms, ranging from 20 to 40. There have been some new studies that suggest those numbers might be closer to 10 or 12, but again, if you recognize that in the population at large, PTSD only exists in 2 to 3% of people, you get a sense of how enormous this problem is. Anxiety, which is not PTSD, which is not depression, is also common in ICU survivors. It certainly has been studied less commonly than depression or PTSD, but in the studies that have looked at it, somewhere between 1/4 of ICU survivors, again, people with PICS, suffer from debilitating anxiety. I think anxiety is a problem that we really ignore in our patients at our own peril. Too often what happens is a patient is evaluated, we conclude they don't have depression, we conclude they don't have PTSD, and then we feel like they must be okay. In fact, there are a fair number of people, anecdotally at least, who appear to have generalized anxiety, global anxiety after intensive care, and it's very, very problematic for them. If we look at PTSD in more detail, there have been over 25 studies done. As I noted earlier, median point prevalence in one review of clinically significant symptoms was 22%. That was from a large N of over 1,000 people. Newer studies, again, suggest PTSD might be lower than previously believed, but we are continuing to determine that even now. The symptoms of PTSD, if you get a sense of what they look like in the real world, are worrisome, terribly compelling. I'll just read a slide here, a quote from Dr. Sarah Wake, who published a really moving article in BMJ in 2013, and I would commend it to you. Dr. Wake says, and she herself was, of course, in the ICU. Dr. Wake says, I would make detours while traveling to avoid the sight of a hospital. I couldn't watch hospital documentaries or dramas. I hid all of my medical textbooks and journals. I enjoyed sport, but began to avoid exercise as I was terrified of the sensation of breathlessness. Even certain inanimate objects filled me with fear. I still cannot bear a shower curtain to be drawn, as it reminds me of closed hospital curtains and hidden death. So what I would submit to you is that there are any number of reminders that people experience after intensive care related to PTSD, and in many cases these are quite individualized. That is, in some instances it's very logical. In some cases the connection is a little less obvious but still significant. Not long ago in our clinic, I saw a patient who was now terrified of elevators. His experience in the ICU had nothing to do with elevators as such, but he had a terror after being in the ICU of being restrained, of being in a small space that he could not get out of. When I saw him in the clinic, he had basically had a panic attack in an elevator at his job after returning to work, and it was very concerning to him because he had to ride an elevator on a regular basis in his job. Certainly, anecdotally and both in the context of objective research that has been done, there's some studies that suggest that ICU survivors, survivors of major surgery, are less likely to seek medical attention than their counterparts without PTSD because they're so avoidant. Slower to go to the ER, for instance, if they have an episode of chest pain, slower to go to the ER if they are having issues of breathlessness or an inability to breathe. The reason is they're concerned that that visit to the ER will result in an admission to the hospital, which in turn will result in being put back on the ventilator. You can imagine how the dominoes start falling for these patients. So the symptoms of PTSD and the points of connection, they are very common, sometimes logical, sometimes not, hugely problematic for patients who are clinically diagnosable with PTSD. This is a slide that's a bit hard to read here, but I included it because I do think it's important. You'll see yellow lines from a legal pad here, and you'll see scribbles from the hand of one of our ICU survivors. number 7 through 10 there. These are examples of persistent delusional memories that this gentleman had, memories that he had had in the ICU that were very terrifying to him, memories that even a year after leaving the ICU he continued to fixate on. He had scribbled these, 50 some odd of them, on a legal pad. He had sent the legal pad to us at the Vanderbilt ICU Delirium Group. That is a copy of the legal pad, and I'll include a few memories here for you to look at. A baby in a jar that had been in a blender but was still intact. Face was still intact. Sarah Margaret dragging the dead baby in the room behind her. The respiratory therapist trying to inappropriately touch me. The respiratory therapist trying to kill me by cutting off my windpipe. So things that, of course, hadn't actually happened, but in the throes of delirium or delusions, this patient was well convinced had happened. He was fully sane. He was in his right mind, as they say, and yet still struggled remembering these hugely disturbing things that he was having a hard time making sense of that were bolstering his symptoms of PTSD. So certainly we need to be concerned about the development of delusional memories, and there's some evidence, emerging evidence, that suggests that the more patients are alert and aware, the more they're fully present in the ICU, less sedated, the more likely they are to remember things that actually happened, and by definition, not to experience delusions. So from a clinical management standpoint, this is one area where decreased sedation probably has clear mental health benefits. That is, people are more likely to be aware and in the present, less likely to have delusional memories, and those delusional memories prop up PTSD. Those comments are illustrated here in this slide in a paper Christina Jones and colleagues published in Critical Care Medicine in 2001. They looked at real memories versus delusional memories. At 2 weeks post-discharge, 73% of patients had delusional memories, 27% had no factual recall. Importantly, those who had no factual recall but had delusional memories were more likely to have PTSD-related symptoms. So there's been this notion that if people remember what actually happened in the ICU, if they're aware of it and remember it, that will cause PTSD in them, when in fact we think the truth is just the opposite, that the more they are actually aware, the less likely they probably are to develop PTSD. The delusional memories are the things we're most concerned about. I highlighted this a bit before. I won't belabor it, but depression is a significant concern in ICU survivors. Occurs in approximately 30% of ICU survivors. We know that somatic expressions of depression related to complaints of pain and physical fatigue, things of that sort, are more common than the classic cognitive expressions of things like hopelessness. Suicidal ideation in ICU survivors is rare. There is a significant co-occurrence of symptoms. Mental health symptoms, of course, rarely exist in a vacuum. In a recent study in Critical Care Medicine in 2015, our colleague Joe Bienvenu from Johns Hopkins showed that 59% of individuals with any mental health condition have symptoms in greater than or equal to 2 domains. So in other words, if you have depression, there's a good likelihood that you will also have anxiety and PTSD. If you have PTSD, it probably doesn't occur in isolation. It will be joined by depression. So this is important. This is important with regard to treatment implications, because when one person has one of these conditions, you should think in terms of them having more. You'll see a chicken and an egg, and I want to highlight an important question that we need to get at clinically. That is depression driving cognitive impairment, or is it cognitive impairment driving depression? This is important to tease out with our ICU survivors. They often themselves don't know the answer to this question, but it has clear implications for treatment. That is, if depression is driving cognitive impairment, then the critical place to focus, the critical thing to treat perhaps, is the depression. It could be that in younger patients in particular, if that depression abates, cognitive functioning may improve. Alternatively, it could be that depression is a function of associated with this new onset cognitive impairment. As with the depression, it could be that if we treat that cognitive impairment or try to improve it through things like exercise or rehabilitation, patients could improve with regard to mood symptoms. So getting at this chicken and egg relationship, what's the fundamental problem here? Is it depression or cognitive impairment? Is it both? That's very important to engage clinically. We certainly know that psychological problems occur not only in ICU survivors, but also in their spouses, and you'll see a slide here that highlights the fact that depression often worsens after intensive care, after things like severe sepsis in spouses or family members as well. Certainly I've interacted with many spouses, and perhaps you have too, who will say that although the patient has no recollection of their time in the ICU, they themselves have a vivid recollection of the death watch, and many will use that term, the death watch they essentially engaged in for days, sometimes for weeks, wondering in the midst of that death vigil whether their loved one was going to survive or not. I've had many patients say, I don't have any recollection of my time in the ICU, it doesn't bother me at all, I don't think about it, I don't want to, and their spouse is sitting next to them say, you know, I don't want to either, but I do think of it. I think of watching you by the bedside and how horrific that was for me. So as you know, we cannot simply focus on patients. We ignore family members at their peril. They need treatment as well. There are physical symptoms under the rubric of PICS. We've talked about cognitive impairment. We've talked about mental health issues. There are physical issues we should talk about, and physical functioning in the context of PICS disabilities often are pulmonary or neuromuscular in nature. We know from literature that various people have published that between 60 and 80% of patients are functionally impaired, particularly in the early weeks and months after ICU discharge. There are various kinds of ICU weakness that have been identified: critical illness polyneuropathy, critical illness myopathy, prolonged neuromuscular blockade, disuse atrophy, and so it goes. Although the consequences of cognitive impairment are sometimes quite nuanced and not obvious, the consequences of physical debility are very apparent and straightforward. If people are physically limited, they often can't drive, they often can't go to the store, they often can't go to work, they can't return to their job, they can't go to church. You know, they really are limited. And of course we know that the more isolated people are, the more risk factors for things like depression begin to take hold. So too often this is a very insidious set of dominoes that starts falling. You're physically debilitated. As a consequence, mental health problems begin to ensue. As a consequence, your motivation to improve the physical problems begins to decrease, and it becomes a really vicious cycle during which activities of daily living are often profoundly impaired. Functioning is also very problematic in ICU survivors. One study showed that of 12-month survivors, 47% were employed at baseline. Of those previously employed, 48% were not working at a year. The main reason people identify for this is health-related reasons. Early mobility, early exercise, and pushing the boundaries and the envelope with regard to early mobility has proven to be very promising in ICU survivors, probably not standard of care in so many centers around the country, but in many leading centers and in community hospitals, this early mobility is increasingly being engaged in and tried. I think this is important for so many reasons. Certainly one of them is that there is this compelling evidence that would suggest that physical exercise, physical mobility is not only good for the muscle, if you will, but also good for the brain, also good for people's moods. So multiple things can happen. Many outcomes can improve when we get people mobilized. You'll note in the study by Bill Schweikert that early mobility has a positive impact on functional status and independence at discharge. You'll note further that early mobility is consistently safe despite the concerns people have about it. We're going to transition a bit to talk about what can be done after the hospital in the lives of people with PICS, whether it is physical debility, cognitive debility, or mental health problems of some sort or other. What happens when people go home? Let's engage this in some detail. There is a crucial gap with regard to education. Often people are not educated about what they're about to experience, and I think we need to improve that. Individuals often fail to appreciate, this is families and patients, that critical illness is a traumatic stressor. So they need to be shown what a disruptive force this critical illness can be in the lives of even healthy people. They need to be provided education to help adjust expectations. Those things could include brochures on what to expect after discharge. People could be encouraged to go to websites with patient and family-centered info. They could be provided descriptions of what depression and anxiety and PTSD looks like. They could be told to be vigilant for those things. Increasingly, we encourage people, and indeed providers are, creating educational materials to form discharge packets to give to patients, and we think that's a good idea. The Thrive campaign is increasingly focused on these long-term outcomes and not simply on their description, but what we can do clinically to try to improve the lives of ICU survivors, and we're going to wade in even now and talk about that in some detail. At Vanderbilt, we have the ICU Recovery Center, and this is a specialized resource that treats ICU survivors with the unique constellation of PICS symptoms. It is a deliberately interdisciplinary team with people from psychology, pharmacy, nursing, social work, etc. We work together to try to rapidly identify needs in our ICU survivors, and then to either treat those as best we can ourselves or to rapidly refer patients. This has been a really dynamic development, the ICU Recovery Center, and this Recovery Center model is proliferating at other centers around the country. It's been used in the United Kingdom for some time. So we think while this needs to be studied in more detail, it is a potentially promising paradigm for ICU survivors. At Vanderbilt, we started in mid-2012. ICU survivors are seen within 2 weeks of discharge. Again, we have a multidisciplinary team. We evaluate patients rapidly and in some cases provide ongoing therapy. We seek to assist patients with critical transitions as they move into their post-ICU life. We use a short assessment battery, or I as a psychologist do. There's a cognitive component. There's a depression component. If you're interested in learning more about these tools, you certainly can contact me directly, and I'd be happy to talk to you about them. Brief screening tools of cognition and depression. There's a post-traumatic stress disorder component also, where we use a short tool called the PTSD checklist, the PCL. We evaluate patients' functioning as well. This is a brief battery that takes probably 20 minutes to give or so. It is certainly not a definitive battery, but a screener, and we've identified many problems that otherwise would have been missed in ICU survivors. With training, people can learn to give this battery. We are focused on rehabilitation in a variety of ways, and others are as well. There is a program called Goal Management Training, which was developed by some neuropsychologists and geriatricians at the University of Toronto. And this goal management training, GMT, targets attention and executive functioning in ICU survivors. We're currently testing goal management training in a clinical program at the VA. It's used clinically elsewhere around the country as well. My goal in this slide isn't to promote any particular method of rehabilitation, but just to suggest to you that the rehabilitation of ICU survivors with cognitive problems may well be a viable strategy and something to consider in the future when we think of post-discharge needs. This is goal management training here. Again, Brian Levine developed GMT. This is a slide from a study of ours that we did some years ago called Return, and essentially what you're seeing here is that patients were given a test called the Tower test, a complex measure of planning, and they were given the test before and after the ICU, the intervention, before and after the actual intervention, the cognitive rehab intervention, GMT. The intervention group is the triangles, the control group is the circles. So what you'll note is that when you look at before and after, there were really no changes in the control group, but quite dramatic changes in the intervention group. They improved dramatically on a test of executive functioning after the intervention. Now, this study had a very small n. It had clear limitations. It was really just about feasibility, but increasingly we're finding, even in other populations, that there are reasons that cognitive rehabilitation may be a viable, effective strategy to improve cognitive outcomes in patients, whether it would be patients with chemo brain, whether it would be ICU survivors, whether it would be people with cognitive impairment secondary to multiple sclerosis. You might say that cognitive rehabilitation is not just for stroke or TBI anymore. It may well be applicable to a broad range of populations. There are a number of important issues we need to engage with patients with PICS, and I'm going to highlight a few of those. Patients have cognitive problems. Patients have problems with depression that could result in concentration problems, focus problems. So we need to ask, are our ICU survivors, are they capable of managing a complex medication regime? What if they don't? What if they're not? How can we help them? How can we determine if they're understanding what a pharmacist is saying? Often at the time of discharge, patients will nod their head yes to almost any question you ask them. And then if I come behind and give them a mental status exam, you'll find that they're quite impaired even though they may not look like it at a glance. So a key question clinically, can they manage complex medication regimens? Do they understand what they're being told? Are they fit to drive? This comes up in our ICU Recovery Center a lot. Anecdotally, we've had many patients tell us that they had their first auto accident ever after they left the ICU. It stands to reason that driving could be a concern given the physical debility they have, given the visual spatial problems they develop, given the muscular weakness, given the executive dysfunction. You might say that in the elderly patients that we see, the surprise would be that they would be good at driving, capable of driving. So are they fit to drive? It's rarely explored. People almost never ask ICU survivors about this. We have referred a number of patients in our ICU Recovery Center to a formal driving program, driving assessment program at our Brain Injury Treatment Center at Vanderbilt. And you may have questions about your patient's fitness to drive. If you do, there likely are formal resources available at your center as well, but this is something we should think about. Obesity, an important issue here. You've probably heard patients talk about the dramatic amounts of weight loss they have undergone after leaving the ICU. We've had patients in our ICU Recovery Center lose up to 100 pounds in the hospital. Patients often joke about, quote, the ICU diet and express anxiety over regaining weight. I've had a number of patients say, my ICU experience was awful, but I'm so much lighter now. That's not how I wanted to lose the weight, but I'm glad I'm lighter. Without that excess weight, I climb stairs much better. So unfortunately, in the absence of education and interventions, the status quo will reemerge. Whatever weight patients have lost, they will quickly pack back on. So whether it's obesity or whether it's smoking, we would do well to be thinking about intervening with patients to try to help them avoid returning to their maladaptive habits and behaviors. Many patients are cigarette-free for the longest period ever since they started smoking. In a majority of cases, while patients are in the ICU, nicotine withdrawal symptoms have peaked. In many cases, they leave the ICU. There's no residual nicotine in their bodies. They come to our ICU Recovery Center begging us to help them not go back to smoking because they haven't had a cigarette since they left the hospital. They're so proud, but they're worried. Without intervention, these patients will return to previous addictive patterns. So you can see the need here for a nutritional intervention. You can see the need here for a smoking cessation intervention. Hopefully you can see the value of both of these sorts of things. Post-traumatic growth is a construct I'll mention quickly. Post-traumatic growth refers to psychological growth that can potentially result from exposure to a traumatic event. For years we've talked about traumatic events fostering the development of post-traumatic stress, and indeed they do. But many patients, anecdotally, will report the positive long-term changes result from the experience of coming face-to-face with their own mortality, that they appreciate their families more, that they appreciate the potential brevity of life more than they did, and they want to live in accordance with that. So we believe that harnessing the power of post-traumatic growth as a way of accelerating recovery after critical illness may be a key therapeutic task. For those of you not familiar with the term, I haven't created the term for this PowerPoint presentation, but this is a term in psychiatry and psychology increasingly used. That is, how can people embrace a traumatic event and use it for their good? We would do well to encourage our ICU survivors to do that. It would require, I think, us to continue to build bridges with people from psychology, from psychiatry, from social work. When we think about ICU discharge, and this is a nice segue, I think, we want to appreciate that transitions are crucial psychotherapeutically, and often when people are ending, they are on their way to moving to what has been called a new beginning. There's a theory of transitions by business theorist Bridges, published here in a book in 2009 that I've referenced, and it involves ending, a neutral zone, and a new beginning. Certainly, ICU discharge, the end of a critical illness, in some ways represents the end. It may represent the end of a baseline level of functioning, and as people recover, they may well realize they're not going to be who they were. By definition, they're going to be someone different than they were, and the challenge for them is to establish a new identity and a new sense of purpose, to realign and repattern. And we can do that as physicians, psychologists, nurses. We can help them succeed across these complex transitions, and really that should be a priority of ours. You're familiar perhaps with the trans-theoretical model of change, widely referred to as stages of change theory, and I would just add here that there's a lot of evidence, data, that suggests that people are often particularly ready to change after a life-threatening event. They've perhaps been thinking about it, they've been contemplating it, but after leaving the ICU, they're in a change-oriented mode often. So using this model where we can help people prepare and move to action and maintenance, we can be very thoughtful in, again, the way that we develop interventions. Again, patients after the ICU, they're particularly amenable to change, so we need to help them along the way and nurture that process that is already in place for them. One of our patients years ago said, speaking of the ICU, I survived, and that's the main thing, and often you'll hear that. That is the main thing. They're so happy they survived. And I'm so grateful to God that I survived, and now I'm off all of oxygen and consider myself all well, except that I can't remember to take my medication. I included this slide really because for our ICU survivors, critical illness, surviving it, it's a mixture of good and bad. Bad, I can't remember to take my medications. Good, I'm so grateful I survived. So they live in this netherworld, in this middle zone between depression, PTSD, much upset over what happened, and much gratitude over where they are, and we have to help them reconcile the happy and the sad, if you will, to walk alongside them and help them make some sense of their experience, to help them form a new identity. That new identity may be an identity of someone who has PICS, but that new identity may also be the identity of someone who is embracing the new challenges in their life, and we need to come alongside them and help them think about doing that. Thank you so much for the opportunity to give this talk. As I close here with this final slide, I would introduce you to a number of resources online for patients and families and healthcare professionals. There's so much to learn here about this phenomenon, and we'll do that working together collaboratively. So thank you so much.